Ladies and gentlemen, we are almost at the last stage of this wonderful conference. The next event is probably one of the most looked forward to events in the Congress as well, and that's the ECG quiz. So could I get the quiz masters onto the stage, please? That's Dr. Suresh Koteguda and Dr. Susita Amarasinghe, both consultant cardiac electrophysiologists. And they will be your quiz masters, and the virtual audience also could take part.
Thank you, Chamara, for that very kind introduction. Right at the outset, I'd like to thank the president of the Sri Lanka College of Cardiology, cardiologist, for the very kind invitation. So we'll get the ball rolling. We start with a case of a 26-year-old gentleman who came with sudden onset chest pain and palpitations. So what is the diagnosis? As we can see, it is a wide complex rhythm, tachycardia, obviously heart rate is more than 100. And then we can see there is a inferior leads we have the positive, but in the chest leads, the bundle branch block pattern is a left bundle branch block pattern, wide complex, fairly regular. So what is the diagnosis? So the options are: is it a ventricular tachycardia? Is it a supraventricular tachycardia with aberrancy, SVT with aberrancy? Is it atrial fibrillation? Atypical atrial flutter. So we can have the voting. So those are the 4 options. So before we give the answers, now whenever we are encountered with a wide complex tachycardia, the question is whether is it a VT or whether it is SVT. If you just say a VT, we are likely to get 80% of the time we are likely to get it correct. But this is a 26-year-old gentleman, so you have to take it in the context of the age and the other comorbidities in this patient. So we all know quite aware about the usual criteria to differentiate the capture beats, the fusion beats, the positive concordance across the chest leads, and dissociated P waves and all that. But I'd like to get your attention to this criteria. It was described by Sasaki, and it's called Sasaki's rule. And number 1 is we check whether the initial R in AVR, whether there is a positive, predominantly positive R in AVR. Pardon me, sir? Okay. So the answers that we got it's excellent actually. So it's a SVT with aberrancy. So virtually everybody has got it correct. But I'd like to tell about the Sakai's rule anyway, Sasaki's rule. And number 1 thing is whether there's an initial R, positive R in AVR. So AVR is one of the forgotten leads, and this is when actually it can come to a help. In this one, clearly it is negative, completely negative AVR. And the next step, if no, we go to the next rule, next step. That is, in any precordial lead, is the interval. I wonder whether this is working. Probably not on the screen, but I suppose I can show it in the, I don't know. The arrow might not work. Anyways, whether in the precordial lead, whether the interval from the onset of the R wave to the nadir of the S wave, make it correct. Yes. So from the initial R wave to the nadir of the S wave, whether it is 110 milliseconds or more. That now in usual wordings, that is whether it is 2.5 small squares or more. If that is so, that means the initial conduction is actually through the ventricular myocardium. That ventricular myocardium is where cell-to-cell conduction occurs, which is slower, which does not involve the specialized conduction tissue system. So that is, there are a whole lot of gap junctions and all. So because of that, it is slower conduction, obviously. And so because of that, it is in keeping with a ventricular tachycardia. In SVTs, the first bit of conduction is always fast, obviously. That is because it is arising from the supraventricular, and specialized conduction tissue is involved. The third step is again whether the initial R or the small r or the small q, whether it is more than 40 milliseconds, that is a 1 small square or more, whether it is more than that. So again, same principle, that is the slower conduction across the myocardium right at the onset. That is what the Sasaki showed. So those three are additional, it's actually 93% since 87% specific sensitive and 93% specific to distinguish VTs. So this one doesn't involve any of these three, this particular ECG. So it is a clearly SVT with aberrancy. Second case, it's a 70-year-old lady brought to ER after being unconscious. On arrival, she was confused. This is in our elderly aging population, this is something that we see far too often. History of hypertension, diabetes, she has ischemic heart disease on treatment, pulse is 50, slow, blood pressure 60/40, low blood pressure, and she's on these drugs, bisoprolol, losartan, spironolactone, aspirin, and rosuvastatin. The ECG, this is the ECG. As we can see, it is slow, so bradycardia, and there is a certain bundle branch block pattern. It's wide. You can ignore these as these are clearly artifacts, because the other leads at the same time shows nice QRS complex. This is as a result of probably a confused patient moving around. What is most likely? Is it hypercalcemia? Is it hyperkalemia? Hyponatremia? Or is it hypokalemia? So we can will it come up in the yes, excellent. So majority have absolutely got it right. It is clearly a hyperkalemia. It's quite evident. The tented T waves are actually, these are inverted, but nonetheless they are tented T waves. Tent is on the other side, because as a result of there's being a right bundle branch block. But this is not just any right bundle. Actually, it is quite a significant wide right bundle. So this particular combination was described. It was described some time ago, but it was put together as a syndrome called Brash syndrome, and this was this appeared in the review article in the Journal of Emergency Medicine just this year, and it's called Brash syndrome. And Brash stands for it is actually a mnemonic. And this patient, as we know, this patient had a sinus bradycardia with a heart rate of 50, peak T waves as a right bundle, and patient had hypotension. Most common cause of bradycardia or hypotension, we can use the word dye as the mnemonic. Dye, that is drugs, that is as a result beta blockers, calcium channel blockers, digoxin, ischemia, I, that is RCA occlusion. It can give rise to severe bradycardia due to sinus node or AV node blockade. electrolytes hyperkalemia. The history of coronary artery disease, of course, and this patient being on beta blockers and ARBs, and patient serum potassium came as 7, creatinine 1.8. It is not a previously known patient with CKD, but it is very likely it is a AKI on a beta CKD. BRAS syndrome stands for bradycardia, renal failure, AV nodal blocking agents, shock as a result, the hypotension as a result of combination of these, or maybe underlying sepsis. There can be urotract infections, that sort of thing, and hyperkalemia. So these patients, when managed properly, make complete recovery, and they don't need pacing or anything. This is clearly metabolic. But this combination we put together as BRAS syndrome. We move on to the next case. This is a 16-year-old girl, epigastric burning pain, relieved with antacids. What is the diagnosis? As we can see, there's a slight, ever so slight widening of the QRS complexes, and not really in keeping with any of the bundle branch, typical bundle branch blockages that we have come to know about. Is it a J-wave syndrome? Are these artifacts? Is it hypercalcemia? Or is the patient with ASD? "16-year-old girl." There are some T inversions, but very likely normal for her. Hypercalcemia. So this is actually known as the Crochettage sign in patients with ASD. This was described in Jack as on R wave in the mostly in the inferior limb leads, and it's an independent ECG sign for ASDs, particularly when you diagnose at a fairly young age, younger than 20 years of age. This is supposed to be quite sensitive. This Crochettage pattern, it appears in R wave mostly in the inferior leads, and is a frequent in patients with ASD, and it correlates well with the shunt severity. And it is independent of the right bundle branch block. Some of these patients with ASDs, actually full right bundle might not be there. In sensitivity and specificity increases as a result of this particular, it's called intraventricular conduction delay. And so it's supposed to be fairly sensitive and specific for patients with ASD. Now, why it is not really a J wave is that we are so used to seeing a lot of J waves in our general population, even though we don't really call it J wave syndrome, because our patients don't really get VF, and it is a we can even call it a normal variation, ECG variation in young people in South Asia. But this particular wave, lead 2, 3 and AVF, actually it is quite taller. It is sometimes in AVF, it is about half the height of the QRS complex, this particular wave. So this is actually not just a ordinary J wave. Yes. So this is actually ostium secundum ASDs. Ostium primum, as you said, it's a left axis. Yes, sir. Okay. This is a 20 2-year-old male who came with precordial pain for 1 day after a session in the gym. So what is this rhythm? It's a narrow complex, normal rate. Is it atrial fibrillation? Is it intermittent complete heart block? I want you to mostly concentrate on the rhythm strip. Is it sixth sinus syndrome? Or is it what is known as isorhythmic AV dissociation? Big word. Someone might question and ask, actually, is it like a Wellens type pattern? But this is something that we frequently see in fit young individual, particularly males. Actually, it is known as a male pattern in Asian males as well as in blacks. 100%. Isorhythmic AV dissociation. Excellent. So that's what it is. It's a isorhythmic AV dissociation. As we can see in the next one, this is actually this is the same patient rhythm strip. This is a fairly uncommon phenomenon. It's not that uncommon. Actually, we see it from time to time, where SA node and the AV node actually competes to become the predominant pacemaker. This is as a result of fluctuating vagal tone in patients who usually have high vagal tone, and fairly fit individuals, high vagal tone, and children, adolescents, we see this fairly often, where you see there's a sinus rhythm, and then here there's no real visible P wave, but actually there is a P wave which comes just after. This is as a result of simultaneous atrioventricular depolarization, and the predominant the pacemaker has become AV node here, AV node. And here you can see a P wave appearing just before. That is as a result of quick conduction to the atrium than the ventricle. And then we can see here like a short PR, again likely junctional beat. You have gone back to sinus rhythm, and again this pattern repeats itself. Again, this is as a result of AV node and SA node competing to be one another. This is like a horse race. Now, all the time, one particular horse might not be leading. There'd be another horse that might jump in front, and this is like a horse race. Actually, this is quite a benign phenomenon. And again, we have to take this in the context of the patient's history. And this is his chest pain is very likely it's absolutely no relationship to this. This is an incidental finding. Again, this is another isorhythmic AV dissociation that we might see, where a ventricular rhythm, ventricular rhythm is competing with the sinus beat. So we call it idioventricular. We can be called as an accelerated idioventricular rhythm. In electrophysiology, sometimes they call it the slow VT. When you say VT again, it causes a lot of concern. But this is again a part of the isorhythmic AV dissociation type. Again, focus in the ventricle is competing with the SA node to become the predominant pacemaker. Of course, we see that quite often during reperfusion after an acute MI. Beta agonist, after if you give adrenaline or isoprene infusion. Drugs, cocaine can give rise to this. Digoxin, electrolyte abnormalities, again as a result of hypokalemia. Cardiomyopathy or carditis, myocarditis. Athletes, they are absolutely fine, and sometimes they undergo ECGs or Holter, and this might appear. And after cardiac arrest, we have all seen sometimes this particular rhythm coming through. That's my last slide. Thank you for your attention. Over to my colleague, Sushitamar Singh.
Good evening, everyone. Thank you very much, Suresh, for that very interesting discussion on ECGs. I would like to welcome the online audience who are virtually joining us. And can we have a count of the online participation right now? Do we have any idea? Because okay, so there's more than what we see here. So changing the pattern, I would like, considering that we have only a bit limited time as well, and since this is the last segment, we will do a rapid firing round of some interesting ECGs. I will be displaying these ECGs for about approximately 30 seconds, and you all can answer the question that follows. So moving into the first question. So these are actual case scenarios that we have encountered over the last number of months on a daily basis. So this is a 14-year-old boy who presented with worsening effort intolerance over 4 months duration, and subsequent echocardiogram displayed ejection fraction of at best 20 to 25. So this is the ECG that was seen. I'll give a few seconds to look at the ECG. And as Suresh described already, so interpreting an ECG like this, it may be obvious for some. And considering that there may be a general crowd joining us, I will let them look at the ECG in a methodical way. So what is the ECG diagnosis? We don't need to go to the real diagnosis. Select the best possible answer out of the 4. Is it a supraventricular tachycardia? Is it a supraventricular tachycardia with a right bundle branch block pattern? Or is it a supraventricular tachycardia with a left bundle branch block pattern? Or is it a ventricular tachycardia? I'll go back to the ECG for a few seconds. And remember, most of the time, this type of ECGs you will see in a very acute setting, either in a ETU situation, and patient may or may not be stable. So diagnosing a condition and managing appropriately, you will need to use a certain standard protocol, so you will not do something inadvertent. Can we have the answer spread, please? It's very interesting. Wide spread of answers. And all right, so that's a fair distribution. And most have selected SVT with bundle branch block, either right or left. We'll have the answer slide again, please. Yeah, so in this situation, it's quite understandable that people tend to think this is SVT because it looks relatively narrow. But then if you look at this in a point of view where you will not miss the worst case scenario, then people should have their doubts more on the side of the more dangerous condition, which is a ventricular tachycardia. So if you look at the, I'm sure you all know how to differentiate SVT from SVT with aberrancy from VT, or the differential diagnosis of broad complex tachycardia. Just to recap, few of the features that we see here. If you look at the axis, it's not the normal axis. Look at the lead 1, 2, 3. It's a clear left axis deviation. And if you look at the precordial leads, V1 to V6, it's all positive. So that is called positive concordance. And if you look at the rhythm strip at the bottom, you can see that there's no AV concordance. So you can see clearly dissociated P waves, where P waves appear only at times. So there are 3 critical features that you can use here to differentiate a SVT with aberrancy from a VT. So it's a ventricular tachycardia. The patient has been having this incessant type tachycardia, and which has led to tachycardiomyopathy. That's a case scenario. So we'll go to the next question. This is a 23-year-old male who presented with ischemic chest pains and many similar episodes in the past. In fact, he has had a cardiac arrest on one of the presentation, and the coronary angiogram revealed normal coronaries, absolutely normal coronaries. So this is the ECG. Every time he presents with typical ischemic sound in chest pain. So on the CCU monitoring, he had non-sustained VTs. And what is the overall diagnosis is the question. So this is his rhythm without when his symptoms settled a bit and the ECG appearance. I'll go back to the primary ECG first and the second ECG. The question is, what is the management of choice? Is it thrombolysis, beta blocker and nitrates, calcium channel blockers and nitrates, or statins? Coronary angiogram being normal. So, sorry. So, we'll give about 30 seconds. So, we're asking what is the right management? Is it thrombolysis, beta blocker with nitrates, calcium channel blockers with nitrates, or statins? We heard about the statins a lot today. Okay, that's excellent. So this is something that we should not miss. This is a very good example where the patient had a cardiac arrest. And if he was not on the right combination of medication, this type of patient might not survive. We all assume coronary spasms a relatively benign condition. It is not. So it can be malignant and fatal at times. This was a classic case where we struggled to manage this patient because he was in and out of NSVTs in goal. Any thoughts from our physical audience, limited physical audience? Right, we'll move to the next slide. Next question. 60-year-old female, history of previous anterior ST elevation MI, presenting with palpitations, shortness of breath, and low blood pressure, compromised blood pressure. And the ECG. Again, a patient who presented to teaching hospital Karachi. Look at the features that we discussed previously carefully and see what we can figure out here. So this is her sinus rhythm ECG, where the rhythm was managed in the acute setting. I'll go back to the tachycardia ECG again. So try to apply the same criteria that we just discussed in the first case scenario. You might get the answer. So what is the diagnosis? Ventricular tachycardia, WPW syndrome, supraventricular tachycardia with left bundle branch block pattern, or a supraventricular tachycardia with right bundle branch block. It's open to answering. While we are waiting for the online answers, we can actually, the physical audience can actively participate. So this is the comparison of the two ECGs. I think the answer is clear when you see this. Can we have the answer? Okay, again, interesting breakdown. And I think this highlights the fact that ECGs, while is a very useful tool, it needs a methodical analysis as well as some degree of factual inferences looking at the features that you see, and it's not really a simple tool. You need to practice it quite a lot to see the subtle features. So in this case, can you have that breakdown again, please? Is it possible? All right, excellent. So it's a fairly even distribution except the number 4 answer, which is, okay, go back to the answers, please. SVT with right bundle branch block. Yeah, that's fine. That's good. And out of the 3 given, So the answer is very clear if you look at the sinus rhythm ECG where there's a prominent left bundle branch block pattern. So the patient in the sinus rhythm still have a left bundle branch block pattern. And when you look at the tachycardia ECG, you can see the left bundle branch block pattern still persists. And during tachycardia, you don't see the concordance of the chest leads. So V1, V2, V3 negative, and V4, V5, V6 positive. So that generally excludes ventricular tachycardia. And the axis has remained the same. Lead 1, 2, 3 has remained the same. So there are, and you don't see any AV dissociation. Actually, if you take trouble to see carefully, there's actually a V association. So there's a retrograde P wave. So all these three features confirm that it's a supraventricular tachycardia with the pre-existing left bundle branch block aberrancy. However, having said that, the take-home message here is the blood pressure is 70/30. The management-wise, nothing much will change here. If you assume it as a ventricular tachycardia, I would have been happier, in fact. Manage this patient as if the patient is having a ventricular tachycardia. You will need a DC cardioversion without much delay. The patient already has a significant cardiac history, so that's not a patient that we can try medical management for too long, including adenosinitis.
Susita, if you apply Sasaki criteria.
Yes, of course. I wanted to actually mention that. Yeah, go on, Suresh. Yeah.
Yeah, if you apply Sasaki criteria, it can't miss it, of course, that it is clearly SVT with
all the
branch
features
block.
you can use here.
Yes, AVR is clearly negative. There's absolutely no positivity in the AVR at all. And none of the leads show any kind of small Q or a small R right at the beginning, which is wide. So that itself basically exclude VT.
Excellent. Yeah, that's a very useful tool. We'll go to the next question. We are running out of time, so I'll try to be a bit quicker. This is a 48-year-old female presenting with shortness of breath and palpitations and the ECG. I can help you. The rhythm is normal here. So what is the most likely diagnosis? Is it mitral stenosis with pulmonary hypertension? Is it acute pulmonary embolism, pericardial effusion, or atrial septal defect with pulmonary hypertension? Yeah, the ECGs again. So is it PE? Is it mitral stenosis? Is it pericardial effusion? Well, each of these answers or the conditions have their own characteristic ECG features. So it's a matter of pattern recognition as well as applying the physiology behind each of these conditions onto ECG features. Again, an interesting spread of answers. So the mitral stenosis as well as PE have been picked up mostly. And I'm a bit disappointed. Actually, the number 4 answer has not, nobody has selected, which I assume is the right answer. So you will see the characteristic features of dominant RAV in V1, which you don't see. If you see this pattern, there are 2 possibilities that you need to look at. Of course, someone can think about pulmonary embolism here. It's not wrong, but if you look at, this is a gradual onset presentation, and generally in pulmonary embolism, you see a right bundle branch block pattern, not a dominant right R wave, which suggests a right ventricular hypertrophy, which is secondary to a generally long-term condition. And in addition, you have classic feature of P pulmonale, which reflects right atrial enlargement together with right atrial enlargement and right ventricular hypertrophy, and without any tachycardia and without the classic feature of S1Q3 pattern on ECG, it is not pulmonary embolism. So in pulmonary embolism, even if you don't have anything else, if it's a significant pulmonary embolism to have ECG changes, you should have some tachycardia. So it's not there. Therefore, the right answer is ASD with right ventricular hypertrophy with right atrial hypertrophy as a classic ECG. A 52-year-old male with diabetes, ejection fraction 45, palpitations for 1 hour with presyncope. The ECGs can look quite similar. So there's another interesting ECG. This is a patient who already has low ejection fraction again. And this is the ECG during tachycardia, pretty fast. It's more than 150. This is the ECG during sinus rhythm on the same patient. You can see it's not normal. So there are quite significant abnormalities on the precordial leads. I'll go back to the tachycardia ECG again. If you now compare the two, I'm sure you have the answer. And what is the diagnosis? Is it VT, AV-RT type SVT, AV-NRT type SVT, or atrial tachycardia? We can have the answers, please. Anybody from the audience, please? So this is the tachycardia ECG again. Well, it has to be either SVT or VT. So, and looking at the precordial leads, you see these are not obviously normal, and the patient has a scarred left ventricle with deep QS waves. Again, quite significant spread of answers. Actually, the right answer has not been picked. So this shows actually the ECGs are really challenging, and these are real cases. So I think it's a good point to understand that the ECG interpretation is not simple. So here again, the take-home message would be: sometimes interpreting ECGs, you have to look at the patient. Obviously, not sometimes, all the time you have to look at the patient to diagnose a condition on the ECG. So if you don't want to miss something life-threatening, always look at the whole patient, the whole profile. You are seeing a relatively young patient with a low ejection fraction, presyncope. Presyncope is a very significant feature in this situation. Sometimes presyncope may not be fatal. In this situation, it's a fatal symptom. So you need to understand that in the presence of a low EF. And with this type of ECG, with the presence of this type of ECG, in the sinus rhythm, you wouldn't assume a tachycardia as SVT unless you are 100% sure, which nobody can be 100% sure. And it's always safer to assume this as a VT, even if it looks very narrow. It is a VT. And sometimes remember the sinus rhythm ECG, if it has aberrancy, the VT can be narrower than the sinus rhythm ECG. So if you see a narrower rhythm, generally it's a VT, while the same patient has aberrancy on the sinus rhythm ECG. Because if it's SVT, it has to present like the previous case where we saw the aberrancy continuing on during the SVT. So this is a classic case where you see a relatively narrow complex tachycardia which is presenting for a VT. So this is a situation where people can do the mistake of managing this patient as a SVT patient.
So Susita, we started the sessions with septal VT and we are finishing with a septal VT.
Absolutely. So this one, in fact, septal VT, but like we discussed yesterday, it's not the idiopathic septal VT, it's a septal VT secondary to a myocardial scar. So yes, very important point. So there are two varieties of septal VT, so LV septal VT.
If I may make a small comment. Beautiful feature that you have shown, your VT is narrower than the sinus rhythm.
Exactly, yeah.
And sinus rhythm is actually wider. So in that is almost like 100% in keeping with a VT. If someone is having a sinus rhythm slightly wider and which becomes narrower, which means it is nothing but VT, which is arising from disease myocardium, and very likely you predominantly using the conduction tissue system. specialized conduction tissue system used by the wheat, isn't it?
Yeah, in fact, it may be using the distal conduction system, distal to the block where the aberrancy occurs. Yeah, that's useful. And we'll move to the question 6. A 36-year-old female, a non-cardiac patient on follow-up, presenting with syncope. So a dramatic ECG that has been recorded on the telemetry on the CCU. The question is, what is the diagnosis? So you can analyze the segments as well as the phenomena that happens and what follows. And the answer is there. So is it long QT syndrome, Brugada syndrome, WBW syndrome, or hypertrophic cardiomyopathy? The ECG again. So we can see a not so nice looking rhythm deteriorating into even worse rhythm, followed by a certain intervention, which is a DC cardioversion, which managed to achieve sinus rhythm only for a while, again going into the arrhythmia. And yeah, so that's an excellent pick. So the right answer is long QT syndrome. The answer is very clear here. You can see how prolonged is the QT. The QT interval, in fact, extends up to the next QRS complex. So if you see carefully, the QT interval is very prolonged. And it's no wonder that the patient goes into polymorphic ventricular tachycardia, degenerating into ventricular fibrillation, requiring DC shock. In fact, this patient has a ICD, which saved her life. And while admitted during an episode of tachycardia, she continued to get these DC shocks, requiring additional beta blocker dosages. The patient is on supranormal doses of beta blockers in addition to the ICD. A 78-year-old male, recurrent syncope. Syncope in various scenarios carries various different significance. And we need to understand it's not always benign. At the same time, we need to have a comprehensive analysis to understand what is the cause for syncope, whether it's a life-threatening one or not. So what is the most likely cause for syncope? Is it a simple fainting attack, a supraventricular tachycardia, ventricular tachycardia, or a ventricular standstill or asystole? The question is most likely cause for syncope. Is it a tachyarrhythmia or bradyarrhythmia, or is it a benign syncopal episode? The so-called benign. I think I hear the answer here. We'll wait for the virtual audience. Can you have the answers, please? It's a very common ECG that we encounter, and it's a common ECG. We have a lot of patients present with significant symptoms, or sometimes takes a while to diagnose. Just one minute. So we have the answer. We'll wait for the virtual audience. So it's looking at the ECG, sometimes it can be easily missed, madam. And well done on the ECG. Can we have the, sorry, yeah. Yeah, excellent. So most of the audience have picked up the features. The three characteristic features that comprises the triphasical block, which is left axis deviation, right bundle branch block, and first degree heart block, or the significantly prolonged PR interval. All were there on the ECG. We'll have the ECG back, please. So well done, the virtual crowd. So yeah, this is the ECG. So you can see the prominent right bundle branch block, the prolonged PR interval, and the left axis deviation. So we'll, in the interest of time, we'll rush through the few remaining slides, maybe a couple of slides we can do. Another classic presentation that we see, I'm sure the audience here will, one of you will know it, and I will pick up straight away. For the virtual audience, benefit of the virtual audience, I will go through the question. 19-year-old boy presenting with vague symptoms, irritable chest pains, occasional breathing difficulties in the night, and family history of young death. This is the ECG. So in our setup, we use mostly the strip ECGs. Therefore, we don't have the standard 12 lead appearance in this ECG. However, when you look at the lead 1, 2, 3 and the precordial leads, you see a characteristic abnormality. I'm sure nowadays nobody will miss this. However, it's important to understand that this is a relatively young man and presenting with a significant family history. Even if we don't see anything on the ECG, this is a very significant presentation. So history is as important as any other investigation tool, and picking up the important points in the history. So it's a case of, do we have the answer, please? Excellent. So yeah, well done. So yeah, we'll go to the next question, please. We have a very limited time, only a few minutes. So 66-year-old male presenting with CVA, left homonymous hemianopia, with a confirmed infarction on the occipital region and the ECG. We know when someone comes with a CVA, we always need to be very careful about the cardiac rhythm. And in fact, it's not when they present with the CVA beforehand. Idea is to detect the rhythm abnormality beforehand and managing them appropriately. And the question is it atrial fibrillation, atrial tachycardia, atrial flutter, or sinus arrhythmia? Bit subtle again, and that's why I selected this ECG. So is it, well, I can help, it's not sinus arrhythmia. I'm sure none of you will pick that answer. The question is it which atrial rhythm? And does it matter, will the management change if it is one or the other? We'll have the breakdown, please. Yeah, a lot of people have picked up atrial fibrillation and some have picked up atrial flutter. So it's a, we'll go to the ECG, please. One slide back. Yeah. For management purposes, there's no difference between by saying it's atrial fibrillation. However, if you look at V1, there are classical organized P waves. And if you look at lead 2 and 3, you will see, if you ignore the QRS complexes, you see the classic sawtooth pattern. So it's an atrial flutter with variable block presenting with a CVA. So for the management purposes, of course, anticoagulation wise, it's the same. So management otherwise will change depending on the rate control strategy and the rhythm control strategy. But as long as the prevention of thromboembolic complication concerned, the risk is the same. So we have to apply the CHA score and decide on anticoagulation before a catastrophe like this happens. So yeah, we will skip this one because we have done something similar. Can we skip that answer? Yeah, I think you can. Yeah, this one also we can skip. A 70-year-old female presenting with palpitations, recurrent UTI, upper respiratory infections, and presenting with this ECG. We have only just 1 minute left. Is it sinus tachycardia, atrial tachycardia, atrial flutter, or atrial fibrillation? We would have preferred to have a physical audience than a virtual audience in discussing ECGs, but of course, we are very happy that the virtual audience is participating actively, and this is going to be the last ECG, so let's see the breakdown on that. This again is a very common scenario. We see answer breakdown, please. Okay, we'll go back to the answers. So most have opted for answer 4, which is atrial fibrillation. However, in this slide, if you see carefully, you can see very nice, well-demarcated P waves, and even in lead V1, it's not very clear. So it's understandable that the ECG can be challenging. However, the important point here is to look at all the leads as well as look at in a methodical way, so that you will not miss certain key features that you can pick up on certain leads. Here you can see P waves which are in fact negative. So meaning that this denotes that the rhythm is not sinus rhythm, as well as it's not originating in the sinus node area. So this is a low focal atrial tachycardia, probably originating closer to the coronary sinus. The electrophysiologists will know where it starts. I think we have to stop. Thank you very much.
Ladies and gentlemen, we are approaching the end of the scientific sessions for this year. And as usual, I would like to invite Dr. Nirmali Amarasena, Senior Consultant Cardiologist, for the final remarks and to present the awards and prizes. The stage is yours, madam.
Good afternoon or evening. As usual, I'm the last. So it's really with great pleasure that I'm addressing you at the culmination of the 20th annual academic sessions of the Sri Lanka Heart Association, now the Sri Lanka College of Cardiology. The year 2020, due to the COVID pandemic, introduced a new normal. The Sri Lanka College of Cardiologists too had to adopt a new normal strategy following this recent second wave that nearly caught us flat-footed. We adopted a hybrid strategy with trepidation, arranging satellite meetings all around Sri Lanka. It was a runaway success. 970 registrations, both locally and internationally, and virtual Zoom meetings in 18 active centers took place. 500 nurses and cardiac technicians participated in the Allied Health Professionals Program. 180 doctors, mostly young cardiologists and trainees, participated in the Interventional Cardiology Program. This was an impressive achievement, exceeding all our expectations. The main academic program, which began today at 7:30 a.m., took us back to basics in clinical cardiology, when clinical science were virtually demonstrated by a senior cardiologist and the patron of the Sri Lanka College of Cardiology, Dr. Ruwan Ekanayake, in his inimitable style. The symposium on updates on cardiac metabolism and heart failure, with social emphasis in the use of SGLT2 inhibitor dapagliflozin by two pioneers in the field, Professor Subodh Varma and Professor Mark Petrie, kicked off the scientific sessions with the highest quality of scientific content. In the nearly 1 hour long Q&A session that followed, where the panel and the speakers could barely keep up with the enormous interest generated by this thought-provoking symposium. In the symposium on electrophysiology, management of sudden cardiac death, presented elegantly by Dr. Rohan Gunawardena, kept our interest very much alive. Demonstrating how an electrophysiologist treats heart failure with resynchronization therapy was virtually dealt with by Dr. Mohan Nair. Dr. Satyaki Nambala served with lunch how versatile keyholes cardiac surgery could be, demonstrating quite complex surgeries done without a sternotomy. Professor Anushka Patel showed her virtuosity as a lead researcher in hypertension trials and the application to the current management of hypertension. Professor George Joseph delivered a comprehensive lecture on endovascular treatment of aortic aneurysms, generating a discussion on troubleshooting aspects with the local participants. Dr. Duminda Samarasinghe, in his lecture on heart failure in children, simplified elegantly and succinctly the management of diverse congenital abnormalities with reference to Frank Starlin's curve. By going back to basics, he brought us down to earth. A symposium on acute coronary syndrome rounded off a particularly successful series of symposia. Professor Mario Mazzilli showed his experience in his discussion of how the transformation of myocardial ischemia from disease to syndrome occurred. Professor Peter Saltis gave a brilliant overview of the current changes in the management of STEMI. Professor Faustus Pinto, no stranger to us, gave a detailed insight into cardiac imaging. The interactive ECG quiz conducted like a duet by Dr. Suresh Kottagoda and Dr. Susitha Amarasinghe, with enthusiastic participation by the physical and virtual audience, ended a particularly successful academic sessions conducted under highly challenging conditions. Dr. Stanley Amarasekara and his team has to be congratulated for rising to this challenge. Now we come to the part where many of our audience, or at least the participants, are waiting for, and that is the e-posters and the oral presentations. So there were 7 virtual oral presentations and 18 virtual e-poster presentations. And these were conducted this afternoon. And after a very comprehensive process, the judges selected 3 winners from each category. So the winners of the e-posters are, starting from the 3rd, that is a study on epicardial pacing after off-pump CABG, not a must, by Dr. M.N. Lansakkara. The second is Alcapa syndrome in a 21-year-old postpartum mother. The winner is Dr. I.S. Vikramatunga. And the one who was placed first is Dr. W.F.R.D. Sovis for his poster on scimitar syndrome in the older adult. Out of the oral presentations, again, the 3rd place goes to Dr. M.N. Lansakkara on aortic vein neocuspidization, the Ozaki procedure, in the presence of proximal aortic pathologies. The second also goes to Dr. M.N. Lansakkara on his approach to mitral valve in infective endocarditis. And the winner, the first place goes to a study in contrast nephropathy among patients undergoing coronary angiography with or without PCI at NHSL by Dr. C.I.H. Sirivardhana. So, is that on? Yeah. Right, okay. So, I haven't got a list, that's right. I believe the final part of the proceedings would be the distribution of plaques to the resource persons. I think that's a fairly comprehensive list. Which one? Oh, okay. Right, okay. Dr. Dhananjani Serivaratna? Not here. Dr. Aruna Vijay Singh? I think if they're present, they should first raise their hands. Dr. Asanka Dunuvilla? He's there. Dr. Janaka Patiraja. Dr. Sitija Vijayasinghe. Dr. Sampath Vidhanavasam. Dr. Jamaldeen. Dr. Dinush Dharmavardhana. Dr. Disna Amaratunga. Dr. Sandamali Premaratna, she went back. Dr. Chaminda Pushpakumar. Dr. Zaki. Dr. Amina Valawat. Dr. Stanley Amnasekara. Dr. Ruana Ekanaka. Dr. Rohan Gunawardana. Dr. Mubarak. Dr. Duminda Samarasinghe. And Dr. Suresh Kottakoda. Me, Dr. Naomi Amarasen. Dr. Sushita Amarasinghe. Dr. Chandrika Ponnam Perumal. Dr. Vasanthi Ratnayaka. Dr. Tisara Samaravikrama. Dr. Mervyn Fernando. Dr. Roshan Padnaman. Dr. Udita Hebaratne. Dr. Sepalika Mendes. Dr. Tanya Pereira. Dr. Sanjeeva Rajapaksa. Dr. Vajra Sehra. That's it. That's the lot. So I think we're done. Yeah. So let us once again congratulate Dr. Stanley Amarasekara and certain members of his team who really worked day and night. I mean, it's not everybody who put that amount of effort, because this was a first time where this kind of hybrid meeting was there, and it was also thrust on them at the last minute. And so many, I mean, even all these virtual sessions and held everywhere was all organized within a few weeks. And there were certain other members who were the non-medical people who also helped considerably. I don't know whether you'd like to say a few words about some of the others who helped.
I think it was so unexpected situation. We have never faced a situation like this for the last 19 years in our academic sessions. And it was with many challenges and obstacles we have come through the council meetings and through the organization. We probably have come to a new normal situation. And finally, those who work very closely with me know, including the council members, the organizing committee, Nimalka and her team, audiovisual organization, particularly Asanga, Malan and Vasana, Chamila, they all worked very hard. And I cannot forget Prabha. She did marvelous job in the office and supported behind the screen. And also almost all the members of the council and the members of the college supported me to achieve this target. And finally, I must thank my loving wife and the daughter who unconditionally agreed to support me and tolerate me throughout this period. I thank you very much for everybody for having supported me. And also I cannot forget the pharma industry, particularly Riza, who joined and volunteered to register people within a very short, challenging period. And we were successful in pioneering his method of registration links giving to people. And we have today completed these sessions with the full success of everyone's support. And I'm sorry if I have forgotten anybody. I will thank to everybody. Thank you very much.